And I have been a physical therapist for almost 20 years now, which is a little hard for me to believe. I have spent time in outpatient PT primarily, and the vast majority of that time in private practice. So I'm a private practice owner, and really enjoy it. Also, I've always had an interest in what's happening in the emergency department. So good friend, Carlene Jagadka, was in my graduating class from Regis. And that's a little bit of why I've been so interested in what's happening with the emergency department and PTs there. So that's a little bit about me.
Who wants to go next? Come on, Addie, you're next.
I was literally just unmuting.
I know. I knew I could count on you.
Had the vibe, yeah. I'm Addie. I've been a PT for almost 6 years now. I'm from Wisconsin. I'm in the Waukesha area right now. I work mostly in like acute care, but I cover the ER as well. We're kind of trying to grow our program down there, and then also trying to grow our like acute care, like labor and delivery program right now. So it's a fun time.
There was lots of good programming on that at CSM that you can get on demand if you are looking.
Yeah, I was looking into that. Yeah, 'cause I
Mhm.
saw that, and yeah, well, I saw there was a lot on that, and then a lot on the ED stuff too, actually. So considering that.
Well, and I can connect you to the people who are doing a lot of that maternal health stuff. They have built a whole network of resources, which is really good.
Yeah, I've taken some of them with Rebecca Seagraves.
Yeah, she's great.
Really leading the movement there. So yeah.
Thank you. Brooke, do you want to go next?
Hi, my name is Brooke. I'm currently a second-year physical therapy student at Regis, and I'm very interested in working in the emergency department.
Ray?
Hey, I'm Ray. I'm a first year at Regis, and I actually heard about this from Brooke because she is my co-chair for the acute care student interest group. And I've worked in the ICU before, and I just never heard about ED, PTs in the ED, so this is all new for me.
That's great. Now, I'm not sure if I'm saying this right, but Olu? Do you want to introduce yourself?
Yes, hello. Can you hear me?
Yes, welcome.
Hello. Yeah, my name is Olu. So I think the full name is Oluwatoyin, but I think Olu is fine. So I'm a PT. I've practiced for like over 12 years. So I started practicing from Nigeria before moving to the UK. So currently I work at the emergency department, and I'm also a researcher as well. So I saw this, and I think it would be an interesting one as a researcher to, to analyze journals and see, criticize journals together. So that's why I joined today.
Well, we will lean on your expertise, I think, as we go through this conversation then. I'm so glad you're here. Isla, do you want to introduce yourself?
Hi, everyone. I'm currently a physical therapy student, so I just have been interested in watching what Rebecca posts. So that's why I'm here.
Oh, you're a little bit more interesting than that. I think you're selling yourself short. Tell us where you are and what you're interested in, because this is not your first journal club, and I'm happy to see you again. I also think we got you connected with somebody in Tampa, right? Did you get to go and do some shadowing?
So unfortunately, no, I couldn't go shadow. But I am currently on my first clinical rotation, so I start tomorrow with a skilled nursing facility. I'm in my second year of physical therapy. I've been interested in a little bit more in regards to emergency department and PT, and also working with tactical athletes. So that's a little bit about me.
Very cool. And you're in Florida, yes?
Yes.
Awesome. I think that Stephen Brock was going to join us tonight. I'm not sure where he is. I got messages from several EDPTs saying, yes, they were planning to come, but they are stuck treating patients in the ED. So that's kind of par for the course. So they may join later. But Jessica, I'm going to turn it over to you to kind of introduce this article, because this article is not really specific to the emergency department physical therapist, right? So what can we take from this article, and so I think when I look at the title of this article, what I like about it is that it's not about EDPT, but it's about factors that are influencing people going to the emergency department with low back pain. And I think that's what we need to know, whether you're trying to start a practice in the emergency department, or whether you're trying to improve the practice that you already have, or even if you're just interested. I think that these factors associated with repeat visits are critical, because one of the biggest things that emergency departments are measured on is their bounce back rate, or the number of patients that can come back for similar complaints or the same complaint repeatedly. And low back pain is a huge reason that people come to the emergency department, and a huge reason to have physical therapists present. So I'm going to stop talking and let you talk, Jessica.
Thank you. And pop in if anybody has questions, just kind of like raise your hand, tell me you want to ask a question, because this is definitely a conversation more than certainly not a lecture, for sure. It's a club, journal club. So I kind of want to start off by, I'm going to list a couple of surprises that I had in this article. The first one being, really, as you said, Rebecca, like it particularly in the outpatient world, low back pain is all over the place. I mean, this is a large group of individuals. We see it's very common. So when this started off and it said it represented only 2 to 3% of emergency department visits, I'll tell you that was my first surprise, since that is not the area in which I practice. And so my question was, for anyone who is in that realm, is that a surprise to you, or is that pretty much what you see? Does that fit?
I used to work in the emergency department for a couple years. I was a scribe before starting PT school. And I was also surprised by that, because I felt like we saw way more low back pain than 2 to 3%.
Okay, that's helpful. Anybody else?
I'd agree. I was surprised by that too. But at the same time, when I look at the track board, I feel like there's also a lot of stuff that we don't even get ordered on, like example, like there's a ton of like abdominal pain or in there all the time. But I feel like, I do feel like sometimes they're listed on the track board as, for example, abdominal pain, but actually I do get ordered for back pain because it overlaps. But I feel like we get called for back pain a lot more than 2 or 3%. But again, I'm not sitting down there all 24 hours a day, so I don't know.
Well, the CDC kind of estimates that it's about 3.15% of all emergency department visits.
Yeah,
so
that was surprising.
However, when you think about that, when you actually like look at the CDC statistics, that is like, I think it says 1.48 billion person years for an incidence rate of 1.39 per 1,000 persons, which is a lot. So 2.6 million episodes of low back pain.
Yeah,
which is a lot of low back pain.
It's a lot. And certainly when we look at this study, I mean, it's certainly a lot of people that it's impacting. I guess I was just a little bit surprised. My perception from my world, of course, is that it's much more prevalent, and probably people are in acute pain and go seek emergency care more often for it. So that was kind of cool. That was a nice learning thing for me.
Well, let me just interject that anecdotally in our emergency department, we see about 24 patients with low back pain per day. So that's roughly 8 per shift if there's 3 8-hour shifts in a 24-hour day. So that's still a lot. We're not seeing and evaluating and treating all of those patients, but we do have approximately on average, if you divide it out over the course of the year, about 24 patients per day with low back pain, which is insane. So even if the prevalence is low, then think about all these other things that people are coming for. It's crazy. Still enough to keep a physical therapist busy.
Absolutely. Absolutely. So, and I'm going to go through, I'm going to list some of these surprises, and I want you guys thinking about surprises, like anything you read and you were like, huh, I didn't expect that. So I'm just going to mention all of mine to begin, and then we'll go from there. They mentioned, of course, this is talking about opioids and NSAIDs, and how opioids are going to increase risk of visit, return, and then NSAIDs are going to decrease it. So I know, I mean, we have literature out there about low back pain and best interventions. We really didn't get any information in this study about manipulation. I was wishing that we had some of that data. So I was a little bit shocked. Like, why are we only talking about pharmacological interventions and not actual PT interventions that, or, I mean, it doesn't have to be PT, it could be DO. We have other practitioners who provide manipulation. So I was surprised at that. Anybody else surprised at that?
The emergency department I worked in, we were a lot smaller. I think we only had like 25 beds. We did have some DOs that worked there, but most of the time, I rarely saw them do like OMT or anything outside of traditional like imaging, medications, let's get you home or get you admitted. And I asked them that, or asked them why, because I was interested in doing the DO route before pursuing PT school. And they just said a big barrier was insurance, and then also time, just like depending on the day in the emergency department, how busy it was, they couldn't spend all of that time with the patient when they had more like higher acuity patients to take care of, or insurance wouldn't reimburse it, or it would just be super, super low. So they're like, we don't always have time for it, and then it's not a big payoff for us. So
I have never seen a DO and RED do any kind of manual therapy. This every once in a while they'll tell me what they think I ought to do, and I'm like, okay, but I'm gonna go do what I'm gonna do. But yeah, I have not yet had a DO like providing any hands-on intervention in my experience either.
Okay, and are PTs doing manipulation in the ED, I assume?
Yeah, I think so.
Yeah.
I don't think we have any data on that.
Yeah.
Like,
so that was it. I was like, wow, we're missing the boat on this. From my perspective, that's a critical number that if you put it side by side with those other numbers, I'm very curious about how that would look. But to Brooke's point, I think the issue is, why would they provide an intervention they're not going to get paid for very much? Even though likely it's the best intervention for the patient, and it would likely decrease their revisit numbers. But anyway, so that was another moment where I went, wait a minute, this is missing something that I really expected to see in this article. So, and the other thing, no mention of any patients who received no medication, or maybe medication, but a referral to PT. We also don't have those numbers. And I assume that's happening, that you're referring out to PT. Like once the PT, like the PT or the MD or the DO or NP, whoever, is referring out to physical therapy clinics for low back pain after an ED visit. Is that happening?
it definitely happens in emergency departments where PTs are present. I don't know that it's happening everywhere, especially if they don't have a good referral network. So I would say probably in hospital systems like ours, where there are a billion outpatient clinics that are associated with that, it's probably a lot easier than if they don't have that like hospital system network. They may not know where to refer patients to. There may also be a lot of like, go back and see your primary care doctor, and then like putting that referral process on the PCP. Part of that is Medicare Plan of Care certifications. Emergency docs do not want to get involved in that. So that's another piece of that kind of limits that referral process. But it should be happening. I mean, ideally, if they're referring to a neurologist or a spine clinic, like they should also be referring to a physical therapy clinic as needed. But I don't know that we have good data on how much that happens in the emergency department setting overall.
Fascinating. So yeah, that was another big glaring hole for me. I thought we need this information. So it was mostly identifying, like, I was just surprised we didn't have any data on that. The other kind of surprise moment for me was that a third of the patients coming in already were using opioids. A third. That's a lot. So beyond being disappointing, I also was curious about how much that impacted their pain threshold and their ability to tolerate pain. So those were, hi, Christy.
Sorry.
Those were some questions that I had about it. So, and some surprises. So anybody else willing to share some of this just off the cuff surprises they had when they read this article?
I was kind of surprised about the imaging one. I can't find the exact number, but like if they received an X-ray, then that reduced their return rate by like 60% or something. That really surprised me.
Right? When it's not clinically relevant, we already know that it's not actually going to change our outcome or improve our outcome. We know that. But isn't it fascinating, the patient perspective and the power that's effectively a placebo effect? I mean, that's what I would call that. But isn't that interesting, right? Yeah, I did find that super fascinating as well. And they address that at the end too, saying effectively, we think this is just because patient confidence that they looked a little deeper into the issue, even though it wasn't necessary. Yeah, I mean, agreed, Brooke. I think that was fascinating. Anybody else have any surprises as they at first blush when they read through this?
I think one thing that surprised me about the demographics was how many of those patients actually had private insurance. Because I think in our head, we're like, oh, the people that are coming to the emergency department for low back pain are people who are not connected and don't have healthcare resources. They're the people with no insurance. They're the people who only have Medicaid, or they're the people that are underserved. But in this particular study, it was actually a little bit of the opposite. Like almost 40% of the patients that they were seeing all had private insurance, which in theory, those patients should be able to access a PCP. They should be able to access a physical therapy clinic outside of emergency department kind of situation. So I was a little surprised by that. I also feel like most of the patients that I see with low back pain are in that like Medicare group. Sometimes they're in that Medicaid group, or they're uninsured. And so I see fewer, I feel like, patients with regular private health insurance with low back pain in the ED. And I don't know if it's just in this particular case that it was an access to care issue, or what the particular reason for that was.
Agreed. Very surprising. I really thought, and also the return rate, even though there was a slight discrepancy, it really wasn't that different between the insurances. I also was surprised that there weren't bigger discrepancies in who was going back to the ED. Anybody else? Okay, so those were some of the surprises. I had a question. Again, some of these questions are actually for people who've been in the ED, but I think for students who haven't been in there, I know, Brooke, you have been, we're all just going to learn together on this from people who've been in there. But how often clinically do you see people getting imaging for their low back pain when they come in the ED?
I feel like it's almost always, like, unfortunately, I feel like even just any musculoskeletal pain, they'll do it as like they almost do it as like a patient satisfier instead of like when it's clinically indicated. It's just to, I mean, I feel like it correlates with what the article said about how like people don't come back because they got an x-ray showing them that there's not a fracture, so they feel better about it. So I feel like that happens a lot for us. Like, I mean, I've had doctors literally say that to me. They're like, it's not broken, but they're really worried about it. So I'm just going to x-ray it for them. And I'm like, okay, like, I'm assume it happens in other places, but I don't know. I've only worked in this one.
Well, apparently they're right. I mean, statistically speaking, based on this, they're right that it's going to make patients feel better and be more confident, I guess, in walking out of the ED. So
it's a little bit different in our emergency department. Like if you have a back pain issue, you almost never ever get imaging. And that's changed over the trajectory of the time that I've been there. So when we initially started there, like it was pretty easy for patients to end up getting an MRI. Now, plain films are very rarely done. If they feel like there is actually risk of fracture, you're much more likely to see them just do a CT as opposed to plain film. MRI, like there's got to be a real reason, like a real emergent reason for a patient to get an MRI for a back pain issue. However, that being said, just like you said, Addie, like if it's an ankle or a foot or a shoulder or neck or a head, like I feel like they're getting imaging like it's, like it's free and that there's an excess of it. But low back pain in particular is something they've kind of moved away from. They've also moved away from, in our emergency department, prescribing opioids for back pain, unless there's a really good reason. So it's just not part of the pathway. And that also, I think, empowers clinicians in our setting to say, hey, I'm sorry that it's not part of the pathway of how we provide care in this facility. Like we don't provide opioids for low back pain. These are the things that I can offer you. So that's just not something that we do. And one of the things that I've shared too with physicians is this Choosing Wisely campaign, which I put in the chat. And it really is the American College of Emergency Physicians advises against lumbar spine imaging in the emergency department for adults with non-traumatic back pain, unless the patient has severe or progressive neurologic deficit or is suspected of having a serious underlying condition. To a certain extent, does it really even add value to image for suspected compression fracture if the patient doesn't have any focal neurologic deficits? The use of kyphoplasty is declining as well. So in some cases, is that even going to really add a lot of value to have a patient go through that? So I think it's a good source to use with your providers about trying to decrease that imaging. There is also a lot of evidence in the emergency department PT literature about reducing the need for imaging if you have a physical therapist present, and we can help make those decisions. And if you're in a state that does allow for you to order imaging, I think that gives us even a little bit more credibility to be able to say, hey, like, why don't I evaluate this patient first? And then we can collaborate together and have a shared decision about whether or not we think this patient might need more imaging.
Mm-hmm. Great. Anybody else? Okay, one more question. I think Rebecca's going to be on the spot for a lot of this, and maybe Brooke, but 3/4 of the visits had patient follow-up, is what it stated. My question is, what does that look like? What does patient follow-up? It says they followed up with a patient. Does that mean they like sent out a questionnaire? Does that mean they actually had the patient seen? What does the follow-up mean in that context?
It depends. Like sometimes patients get a patient satisfaction survey. Other times follow-up might mean that they were referred for follow-up, whether or not they got that or not. But there's certainly not like somebody calling and checking on these patients to make sure that everything's going okay. The only time that I think really happens is if there are results that they get later that needed to be delivered, like a culture or something like that. The results later, like especially during COVID, we would test people for things and then send them home and then call them several days later and be like, oh, it turns out you had COVID that whole time. And they're like, sweet, I've been at the grocery store and the school. And so I think that's primarily, I don't see a lot of like personal follow-up happening unless it's part of a research protocol or something similar.
Yeah, well, I was surprised. I was like, I don't know that 75% of people are getting followed up on from the ED if they go in for low back pain. I don't know that that's, and so that was another kind of interesting thing. And I wanted to flesh that out a little bit. So since we have many students in the room and some more clinical experience, I might flip this script just a little bit. And I want to ask people have you ever seen someone in the clinic for low back pain and referred them to the ED? If so, why? I can start with a story. Do you want me to start with a story? Okay, I'm gonna start with a story. All right, so I was probably 2 years out of Regis, and that was my PT program. And I was in the clinic and I was seeing an older gentleman who's probably about 60. Which now that I'm getting closer to that, I think that's pretty young. But anyway, so 60-year-old man, and he came in for low back pain. And so I treated him once, gave him, you know, some basic stabilization stuff, did a little manual, and he came back 2 days later. I walk out to my waiting area, and he is like leaned over, and he has like a garbage can, and he's about to throw up, and he's sweating, and he's a little pale. And I was like, oh, okay, why don't you come back into my room? And he's like, yeah, those exercises you gave me were really powerful. And I thought, I mean, I think my interventions are powerful for sure. However, based on his presentation, I was fairly confident he was more likely passing a kidney stone at the moment. So I just wanted to get him out of the waiting area and lying down and comfortable while I called his primary care to find out if they had ultrasound or if I needed to send him an ED. So I got him, did get him back to the room, got him lying down, called, and they said, yes, send him in. And I told him, I'm not diagnosing you, but it's very possibly have something like a kidney stone, and sent him in. Sure enough, he did. So it was, it was kind of textbook, but as a newer grad, that was a really helpful learning experience for me, just because you know what it looks like in real life, right? You read about it, and that was just a moment where I went, clearly this is not an MSK issue, like this is visceral. That kind of presentation, that kind of pain does not happen quite so much. So outside of a fracture, of course, an acute fracture. Okay, anybody else?
Well, I had a patient that kind of looked like that came to the ED, obviously, but he was sitting in the waiting room, pouring sweat, like holding a bucket, like looked like really unstable, looked like he was going to pass out. The PA and I both looked at this patient like, are we actively dissecting right now? Like, what is happening here? Like, couldn't stand up. We brought him back, his blood pressure like through the roof. And the PA was like, hey, maybe like, let me take this before you see this patient. And I was like, it's valid, like, go ahead, like roll through, like do what you need to do. And his presenting complaint was actually a fall. He had fallen down the stairs a couple of days earlier. And, they did do imaging because he met the imaging guidelines for traumatic fall. And he had several spinal fractures, like severe spinal fractures, and had just been like chilling and walking around and going to work and all that. And then like that morning, he just physiologically could not do it anymore. He had been that self-employed guy who was just trying to like gut it out. And in that case, it was kind of the opposite. Like he looked like there was this horrifying visceral process going on. And it kind of was. He had multiple fractures, but there wasn't actually anything else like systemically happening. And in that case, there wasn't a whole lot I could do other than brace it because it was pretty gnarly. But he was able to, with pain control, like participate, and like his physiologic symptoms all kind of like went away, like a wave that just came and went. But this man was just like literally overwrought with pain at that point, and he had bounced down concrete steps on his back. So it was kind of the opposite of that, where I thought for sure like something was really grievously wrong with this patient, and there was, but it wasn't like life-threatening.
Fascinating. Anybody else?
I think one interesting question, if nobody has anything they want to share about that, because I know it's hard to have for students to have that, is there was another article that just came out on patient perspectives on seeking emergency care for acute low back pain and access to physical therapy in the emergency department. So one question people always ask me is like, why would you go to the ED for low back pain? Like, why would you even do that? And I think this article was really interesting to me, and like it really did measure and ask the patients, why would they come to the ED? So my question, I guess, for you all is, why do you think a patient would go to the ED? And if you're in an outpatient setting, or even if you're in a subacute rehab facility or in a home health setting, why do you think a patient would choose to go to the emergency department for low back pain? And then what are indications for actually sending that patient to the ED for low back pain?
Go ahead, Christy.
I can. Hi, everybody. I've been in the practice for 20 years now, and I think when patients have called me to their house, like if they have my phone number, it's been because of acute back spasm, like so bad that they can't get off the floor, they can't get up to go to the bathroom, they're just like in such acute spasm that they can't move, and it's like they're scared. And so I think that's the main reason I've seen it. And it's not like the neurological, like something like that. It just seems to be a little more of that musculoskeletal issue where it's really spasmed. And I think the best way we've treated it, I mean, I'll go to their house and maybe do some, dry needling, or like really try to help them at least get off the floor. But really sometimes those over the counter, like the anti-inflammatories, are the best thing to do. Like, the steroid packs might be the best way for some of them to go. But that's been my experience as far as like who would go to the ED is probably, from my experience, just the spasm that happens. And then we get to the underlying after that acute issue is over.
I think you're right, because a lot of I think really concerning low back pain symptoms, the ones that I'm like, oh, this patient needs to have an MRI, for some reason do not seem to startle patients. Like I find that a lot of those patients are like super chill. They're like, yeah, I've been dragging my foot for 3 weeks. So I'm like, it's not good. Like that's not normal. But that like back spasm is incapacitating. So when you really reduce a patient's ability to participate, I think that's when it becomes more of an issue for them and more emergent to them, where they're more likely to prioritize that visit to the emergency department. I also see a lot of PTs from outpatient clinics. Jessica, maybe you can speak to this a little bit, sending patients in because they're in 10 out of 10 back pain, but then they just see me. So I think that as outpatient clinicians too, we need to try and work with patients a little bit more about that pain control outside of the emergency department, if there aren't any other red flags, obviously, or any other really serious concerns, because otherwise you're sending them to the emergency department for a very expensive Tylenol, ibuprofen, and a lidocaine patch. And maybe they'll see a PT and maybe they won't. And I think the other lesson that patients learn from that is, if I'm in a lot of pain, I should not go to PT. And I don't want that lesson being learned by patients either, because we're really the best people to help them.
Totally agree with you. Yeah, and I think, stories that I hear, so not necessarily people that I've seen in the acute situation, but I've had multiple, there are two kind of, if I were to say there were trends for people that have told me stories about going to the ED, back spasm, like Christy said, debilitating back spasm. And those, I think, tend to be one of two things primarily. And one was, honestly, it's like a psoas spasm. They can't stand up straight. They're having maybe some almost visceral abdominal type pain, but they're definitely having some back pain too. So psoas spasm is something that has, once I start working on psoas, and this is in a subacute phase, they light up and they're like, that is what was hurting when I went to the emergency room, and they told me I was fine. The other scenario I've heard, unfortunately more than once, was debilitating back pain that had just gotten worse over time, and cancer. That's happened, not to me, that I've seen people in an acute phase with that, but that's been the outcome for several people. So those are the ones that I have heard of, but I think the psoas spasm happens more often than we actually realize. I think the reasons I would send people, like I talked about, and to be clear, I did ask this gentleman, the 60-year-old gentleman, a few more questions, like, are you have any changes in, urination? Or, I mean, I'd asked him a few questions, so I pretty much knew what was happening. But anytime you see that type of pain, that the cold sweat, pale, either I'm thinking, again, kidney stone, something visceral, fracture, something is there beyond what I need to treat that day. So those are reasons I would send people. Or if we need imaging and somehow, I have found this, we are not making headway in primary care offices. They're just not being taken seriously for whatever reason. There are occasions where I have had people go, so we make sure we get imaging done. And that is why I'm sending them there. But that's happened once or twice, probably in my whole career. So anybody else?
Can I just ask a question, Jessica? Are you prescribing imaging, or are you referring for that, or can you do that?
We can in Colorado.
Yeah.
We can technically, legally, it's sort of like direct access.
Yeah.
Yes, we can. The question is, will their insurance pay for it? So oftentimes I am not going to jeopardize them fiscally by sending them directly, because I don't know. Like, I don't know if their insurance will pay or won't pay if I'm the one referring. So I tend not to, but I know other PTs in the Springs who are referring for imaging. Again, legal here, I personally am not doing it a whole lot. So what about you? Are you doing it much?
Only for X-ray because of that reason, but not MRs or anything beyond that.
It's much cheaper to go to an outpatient imaging center than to go to the ED.
Yeah, well, which is where, yeah. I mean, often what I will do, I mean, there are a few cases like that. Mostly what happens is I call the primary care doctor.
You know, and I think that makes sense. I was at a session at CSM where a PT was saying that he would, if he thought his patient needed certain types of imaging, would coach his patient to crawl into the emergency department and say that he couldn't not use his leg and that he'd be dragging his body. And I'm like, please don't do that. Especially right now. Like, access to care is so difficult. Emergency departments are quite full. Like, just have, if you're really that concerned and you think they need an emergent evaluation, please just have them come with their regular symptoms. Like, we don't need to coach anybody into anything. We need to find out an accurate picture of what's happening with the patient so that we can act quickly and appropriately and not have to sort through artifice. So that was an interesting perspective that I heard at CSM in that particular case. And I just want to make my position on that clear. Please just send them in with the symptoms that are bothering them and let them tell their story. And you can also give the patient your contact information so that somebody can call you to find out what the concerns are if that's necessary as well. Yeah, I think if you're going to take the time to coach them on something like that, you probably just as well pick up the phone and call their primary care doctor. I agree.
Made some headway that way. Advocacy for sure, because I know there are times where, again, maybe their PCP's office is overwhelmed, whatever it is, they're just not getting the care that they need. And no matter what, low back pain, whatever. I've certainly done that lots of times, and they're always receptive. I really haven't had issues with them not being receptive once I make that phone call. So that would be my preference for how to go about that. So yeah, anybody else on that? Any other outpatient stories or thoughts on when you'd refer?
I just wanted to get a clarification from something Rebecca said earlier about people not going to PT because of that cycle of what happens when they go to the emergency department just to get expensive Tylenol. Can you clarify that? I'm not sure the connection of like.
So if you have a patient who comes into your PT clinic and they're in severe pain and your response is to send them to the emergency department and not intervene, they're going to go to the emergency department. The emergency department physician has basically two options. They have imaging and they have prescriptions. And because of the opioid epidemic, they are very unlikely to prescribe any kind of opioid to help with that patient's pain relief. So they are likely to be offered Tylenol, ibuprofen, and a lidocaine patch, which there is an agreement on within the physician community on how to best manage low back pain in the emergency department. There's some articles about like discussing what best practice is, but that tends to be pretty common. So that person's going to go to the emergency department, have an emergency department bill, and end up leaving with something they probably could have taken at home. And then they still didn't get any physical therapy evaluation or intervention. Now, if they're in an emergency department that has a physical therapist, hopefully they get Tylenol, ibuprofen, a lidocaine patch baby, and a physical therapist. But then that patient has learned that PT is not the right place to go if they're in a lot of pain. Because they came to you with acute severe pain and you said, I can't help you with that. That's an emergency. So now you've heightened that patient's concern about the pain. So you've like escalated that nervous system response to the pain, told the patient that's an emergency and it's dangerous and you need to be seen in the emergency department. And I'm not equipped to help you with that. Now, there are times when that's appropriate, where you absolutely, as an outpatient physical therapist, should be sending patients to the emergency department with 10 out of 10 uncontrollable pain. But I would argue that in most cases, we should at least try to intervene before we're sending the patient to the ED, particularly if the patient has already made it to you. Because they have already made it to you. They didn't call an ambulance. They came to you. They came to you for help. So try and help them. It's one of those things where you're going to treat and refer maybe, or just refer in certain instances. But I think that like attempt at, can I modify this patient's pain? Can I help discover, is this musculoskeletal pain? Or is this something that's a little more sinister than that, that really does need to go to the emergency department? But we truly are the experts at delineating, is this a musculoskeletal issue or not? And I think it serves our patients well for us to at least kind of sort that out a little bit before we're just like, hey, you need to go directly to the ED.
Yeah, and if I were to send them to the ED for that reason, I would have written down some very specific things like noted bowel and bladder changes, night pain, unrelenting night pain. I would kind of list off my like red flags all over the place. My vitals, right? I would have written down what the vitals were to show they might be in some distress if I assume heart rate's high, blood pressure. I would write down some things to kind of cue in people in the ED, like this. We know this is not just something I want to treat, in my clinic right now. And will you please look at these things? This is what's been flushed out, or this is how they presented when they came to my office. Most of the time, though, it's going to be a primary care doctor type call or referral. And again, like sometimes I call and say, can you see them right now? Like, can you squeeze them in? And they will often accommodate that too. So that's another thing that maybe other people are using, I assume, too, but that's something I absolutely do on a fairly regular basis if something like that is, going on. But I think I'll do anything to not send them to the ED unless I think visceral or something well outside my scope. I will almost always try psoas release of the back pain or long axis manipulation if they're if they fit the criteria that they would respond to that. No symptoms below the knee, etc. So
does that answer your question?
Very much so. Thank you.
Jeannie, Kyle, hi.
Okay, so anything else? I mean, I felt like it was a great article, even though it left out, again, some of the surprises that I had. I wanted to see a lot more about what happens when you send the PT out, or if you actually do perform specific manipulation or something when they're in the ED. We just don't have that data yet. So outside of that, I did think it was very helpful because this is a powerful tool to talk about opioids versus NSAIDs. Even in the outpatient clinic, that's helpful because we have to do so much patient education when people are on opioids or they're afraid to get off of them, or post-op. I see a lot of folks who are given opioids, and the sooner we can get them to something a little more mild, the better. And sometimes these types of studies help beyond just this, right? It helps me to say, actually, there's a great study that talks about how much more impactful, NSAIDs are as opposed to opioids for managing low back pain and recurrent low back pain. So I sometimes use this type of data to help inform patients about what they're using for their pain management beyond PT, as I'm working with them. So I felt like it was helpful in that way also, but also very interesting to see, again, some of those things about it being only 2 to 3% of people visiting the ED. So maybe, Rebecca, maybe that means it is being managed outside the ED in lots of ways, hopefully, and we're not just sending them all to you.
And maybe it's not being handled in great ways, right? Because we know how much the healthcare system is spending on low back pain. But I think one question that I have for you and other outpatient therapists that are joining us tonight is, for those of us who are in the emergency department and are seeing these patients with low back pain, what are the best ways that we can really manage up and prepare them and like manage their expectations for what they should expect when they come to see you in the outpatient clinic?
So when you're seeing them in the ED, how can you manage their expectations? Would you refer them to PT? Is that what you're
So
asking?
how can we like best prepare them to come and see you and for like that process that's coming next?
So, bringing down that sympathetic nervous system and calming them down and making sure they know they're not going to die. That's helpful for us. It sounds silly. I'm not being flippant. That's true.
That's job one for us, right? Because especially if they're coming out of an ambulance, like that's job number one. How do we like decrease the heightened state that you're in right now so that you can actually attend to what's going to happen next?
Right. Educating them, patient education, that's really helpful for us so that if we say the same thing that first visit, wow, this looks like we have, some, nerve root irritation at L4 based on where it's, presenting. And this is because this is what a dermatome is, and this is how we can tell, even though you didn't have imaging. And then if that is the same as what you're saying in the ED, there's some confidence with that. So that patient education piece is, as much as you have time for, I know there's not a ton of time, but that's helpful for us. Also, what to expect. The therapist is going to evaluate you and take a good amount of time to look at your past medical history and figure out exactly what is going to help you progress through. Be patient. Sometimes it's going to take, a few visits, but the outcome is much better if you go. Those would be things that I think would be powerful for them to hear while they're in that very acute pain state. It also gives them an expectation that they're going to feel better. Christy, or anybody
Yeah, and
else? Go ahead.
I just piggyback on that as far as exactly the patient education pictures and, showing all of that. And then timelines, of course, everyone loves, and that's good for the expectations as well. So I think having like our goal is to get you out of pain, and this is why you have pain. And then this is what you can expect. And if we're not along our lines, we have plan B and we have plan C. But right now, plan A is going to be the most helpful for you, or like we can at least kind of not sell them, but explain it that plan A should work. And if it doesn't, we do have a backup plan. So getting that kind of that peace of mind as with the patient education, that this isn't our last straw. There's other things if we need to go that route, even though we're probably capable of handling it.
Anybody else have thoughts on that?
And I should say, Christy, Kyle, and Jeannie, do you guys want to just introduce yourselves briefly and tell us where you are? I mean, Christy, I know you, but if you guys want to talk about where you are and where you're practicing, that'd be awesome.
I'm Kyle Knopf. Work in emergency department in Madison, Wisconsin. I apologize. That was my kid's PTO meeting. That's why I'm late.
Thanks for joining us.
I'm Christy Kohler. I work, I was in Colorado Springs for a number of years. Now I'm up in the Boulder area, and I own my own small outpatient clinic. And then I recently started also with UC Health. So I'm kind of juggling the two. and outpatient ortho. Yeah.
Well, I'll have to send you some patients from the ED.
Is that where you are?
At Anschutz, so I can.
Oh, you're Anschutz. Okay.
Uh-huh.
Sorry, I missed introductions.
That's okay.
Okay. Well, that's cool. I was curious about how PT was in the ED. So maybe we can connect. And I was at CSM also.
Awesome.
Yeah, it was a good time.
What I don't understand, so Colorado Springs to Boulder, like that's a very like landscape is exactly the same. Lifestyle 180.
No. I
Okay.
would say it's about the same.
I feel like even like the trash can choices in Boulder are much different because you've got all of your different composting things. I get very confused.
Okay, the politics might be different, but
Maybe just a little.
the lifestyle is pretty similar, actually, right, Christy?
Yeah, for sure. I miss the
We're
Springs.
around uber active.
Everybody's
people.
outside all the time.
We have the Olympic Paralympic people here. It's nuts, just like Boulder in that way.
Yeah,
That's
I just signed
fair.
up to be a Ascent, so wish me luck.
Very cool. That's
Scary.
exciting.
Yeah, kind of.
Awesome.
Anyway, yeah, we should connect though with Anschutz. And are you going this weekend to the women's wellness?
No, I have to work
on Saturday. Okay.
and Sunday. Yeah.
Okay.
Welcome to the ED. Yep.
Okay.
Jeannie, hi. Go ahead and introduce yourself.
I can't hear you. Can other people hear her? No, somehow we still can't. No, you took yourself off of mute. I know. Any troubleshooters? Anybody good at troubleshooting this?
Jeannie, do you want to try the chat? This is going to be the most epic introduction ever. Oh, that's awesome. Where are you located, Jeannie?
Cool. Oregon.
Very cool.
All right. I went to Linfield, not far away from George Fox. Very fun.
Well,
That's exciting.
congratulations.
Yes,
I used to
congratulations.
live in McMinnville. That's a good state. I'm from Oregon.
McMinnville, we love to call it.
I think we are about out of time. So I just want to ask if anybody has any final thoughts or any questions, anything they want to bring up. Last minute. Okay, well, I appreciate you all being here. Jessica, thank you so much for being with us and helping us get through this article. We will have another journal club in the second quarter of this year, TBD, topic and date and time. And also just share some upcoming events. We will have another How to Start a Thriving Practice course in Boston in September of this year. And for students, if you are going to be in the Boston area or are in the Boston area, we will be presenting at the conclave out there in April, just to give a little bit more information to students about emergency PT. And those of you at Regis, I'll be coming soon to talk to you about best pathways on how to get into the emergency department, as opposed to just what do ED PTs do. And if I can be a resource to any of you, please feel free to reach out. You know how to find us. And thank you all for being here. Have a great night.
Thanks for having me, Rebecca. Thanks for coming, everybody.
Night.
Thank you.
Night.